Patients who relapse or are refractory to frontline R-CHOP chemotherapy, the standard treatment is generally salvage chemotherapy followed by high-dose treatment and autologous stem cell transplant. That's been the standard of care for the last 3 decades. But unfortunately, there's a good proportion of patients, generally half of patients, who suffer relapse or have refractory disease who are not actually eligible for transplant. And that could be because they have chemorefractory disease following salvage treatment, or the treatment itself is deemed to be too toxic, and that could be because of advanced age or comorbidities. So for this latter group, there's no established standard of care. So if they're not eligible because of frailty or comorbidities, these patients generally have a very poor prognosis with a median survival of 6 months and are often palliated with various treatments. So this represents an area of unmet need for the population. The phase 2 pilot study that was presented by Dr. Ghosh is the first study assessing the safety and efficacy of CAR T-cell therapy, specifically Lisocabtagene, as second-line treatment in patients with relapsed refractory large cell lymphoma who were deemed ineligible for high-dose therapy and autologous stem cell transplant. And the transplant non-eligible criteria included advanced age, and they defined it as age greater than or equal to 70, poor performance status with an ECOG of 2, and or moderate organ dysfunction. And these would be standard transplant eligible criteria such as LVEF, DLCO, creatinine clearance, and liver function. So when you look at the transplant eligible guidelines across the country, these are pretty standard. Most centers do use age 70 as a general guideline cutoff for appropriateness for transplant. Certainly there's always going to be the exceptions to the rules for patients 70 to 75, but these are generally the highest fit patients with an excellent performance status and no concurrent comorbidities. The primary endpoint of the study was overall response rate, but other factors included adverse events, CR rates, and survival outcomes. So it was a small study with 29 patients that were enrolled, with the median age being 72. And 76% of these patients met eligibility criteria based on their age more than 70. 31% had an ECOG of 2, and similarly, 31% had a comorbidity. And in fact, the most common comorbidity was renal dysfunction, creatinine clearance between 30 and 60 mils per minute, with only one other patient enrolled for another comorbidity, in this case, LVEF, between 40 and 50%. 62% of the patients had more than one criteria, so age alone was not the only factor in 2/3 of patients. The study also looked at the mean HCT-CI score, which is often used in the transplant world to estimate non-relapse mortality risk with intensive treatment. And the median score for this patient population was 3, which is considered a higher risk for NRM. This is a high-risk group. So this population, half of the patients had primary refractory disease, a third of the patients had double-hit lymphoma or triple-hit lymphoma as their subtypes, and high-burden disease, defined as an SBD more than 50 centimeters squared, was seen in 37% of patients. The follow-up of the study is short, and about 5 months, but to date, the overall response rate was quite high at 89%, CR rates 56%, and partial remission rate at 33%. 2 patients who achieved a PR initially at the day 28 later converted to a CR. In terms of toxicities, grade 3 to 4 toxicities were seen in 69% of patients, the majority of which were cytopenias, with prolonged grade 3 cytopenia seen in 28% of patients. CRS events in general were low, but 21% of patients suffered CRS, and this was only grade 1 and 2, so there was no grade 3 or 4 CRS events. Neurotoxicity rates were also low. Only 3 patients suffered from neurotoxic events, 2 of which were grade 3 and 4. And there were no treatment-related deaths in the first 30 days of therapy. So taken together, this particular group of patients who would generally be considered non-transplant eligible across the country, when they received treatment with Lisocabtagene, this actually resulted in excellent response rates, an acceptable safety profile. And this is similar to what's already been reported with the other major Lisocabtagene study, the Transcend NHL 001 study. So it really just tells us that what we would consider as frailer patients, or patients we're not sure would make it through the intensive treatment that would be required for stem cell transplant, would be able to tolerate CAR T cell therapy better and actually enjoy the benefits of receiving such treatment. Obviously, the follow-up period is still short. And we're going to need some more time to look at the durability of the treatment response, and this will be further updated with more long-term follow-up. But at the end of the day, we'll be making decisions for these patients who have no other options, who we think would benefit from a treatment such as this, and really, if they can tolerate it, they are likely to enjoy a significant impact on their overall survival, versus the alternative, for the most part, which is generally palliative treatment.